Hello friends, this is a 40-year female with the acute and chronic cholecystitis, and we will perform the laparoscopic cholecystectomy, and for cystic duct we will do ligation of the cystic duct. So, let us start the surgery. We are applying 2 Ellis forceps on the everted crease of umbilicus, and the purpose of this Ellis forceps is just to make the inferior crease of the umbilicus prominent, and here 2 millimeter stab wound is given over the inferior crease of umbilicus. After that, lifting the abdominal wall with the left hand and putting the Veress needle towards the anus, so that it should be perpendicular to abdominal wall but oblique to the body. An advantage is that it will not slide over the peritoneum and it can never go to the bowel or any vessel. So, this is very important that you should be perpendicular to abdominal wall but oblique to the body, and after that we will just check it by irrigation, suction and hanging drop test. So, this is the confirmation that once your hanging drop test is pulled up, that means you are inside the abdomen, and in the disposable Veress needle there is one green indicator also, that also will help you to decide that you are inside the abdomen. After that we are starting the flow, and here preset pressure is kept at 15 and we are waiting for slowly actual pressure to reach to the preset pressure. And we can see homogeneous distension is started and slowly actual pressure is reaching to the preset pressure. And as we know that flow of Veress needle should be 1 liter per minute, so that even if your Veress needle go to any vessel, there will be no air embolism as long as your flow rate is 1 liter per minute. Now, we will enlarge the incision in a smiling way, and that will be 11 mm enlargement of the incision, so that we can put the optical port, and only a skin should be enlarged, not the rectus. And after that, with a mosquito or Kelly's clamp, you can dilate the obliterated vitreointestinal tract, and that is a part of, that is called a Scandinavian technique. After that, we will put the optical trocar, that is a pyramidal tape trocar, and we are applying little betadine at the tip of the trocar. Head of the trocar should rest over thenar eminence, middle finger should wrap around the air inlet, and index finger should be pointed towards the sharp end. And then by a screwing movement, this optical port is introduced inside the abdomen. Now, this is the hissing sound which will come out once you are inside the abdomen and now the telescope is getting introduced. Now, we will put the second port. First, initial diagnostic laparoscopy should be performed, and once everything is found, then this is the second port, that will be just below the Giffy-sternum. So, right thumb is palpating the Giffy-sternum and left index finger is putting it approximately 1 centimeter below the Giffy-sternum, and then incision will be given half centimeter below the Giffy-sternum. And that is also 10 mm port, 10 mm incision. Initially it should go perpendicular, this trocar, and after that it should go towards the right side, so that you can puncture the membranous part of the falciform ligament, and it is introduced in. Now, the third port you have to put the head up and the right tilt, and then third and fourth port will be introduced, and third port is mid clavicular line just below the costal margin, and that your assistant can introduce, because you are on the left side and your assistant who will hold the fundus, he is on the right side. So, you can ask your assistant to do or you can also do, but assistant has to do some work. So, here he is putting the two 5 mm port, one at the mid clavicular line and another at the anterior axillary line, 7.5 centimeter lateral and 7.5 centimeter below the third port or at the level of umbilicus on the anterior axillary line. And these two ports must be introduced under vision, which your assistant is looking on the monitor, which is on the head side of the patient. And now all the port is introduced, and after that you will introduce a grasper for the assistant to hold the fundus of the gallbladder. And then first what we will do in this case, you can see a lot of adhesions are there. So, first step is to do adhesiolysis, and now assistant is retracting the fundus towards the right shoulder and further adhesion will be removed. These all adhesions are the old adhesion due to previous cholecystitis. So, more episodes of cholecystitis patient will have, more patient will delay in the surgery, there will be more adhesion. So, these all adhesion is getting separated, and slowly by a stripping technique you can remove it. However, the good thing about these adhesions are that this is not a adhesion of duodenum or transverse colon. So, these are the omental adhesion which can be separated easily by a stripping technique. And sometime if you have a thick fat pad, you can use the harmonic also to cut it down. And slowly all, now we can see that we are now at the level of Hartmann pouch and Rouvier sulcus is also visible. So, now the left hand is holding and then further adhesiolysis is carried out. So, you can coagulate, cook and strip down. So, these all adhesion has to be separated, and the first step of all the surgery in many of the cases in laparoscopy is adhesiolysis, and these all adhesions is separating. Now, we can see in this patient there is a 2 centimeter stone on the Hartmann pouch. So, with the right hand grasper, first we will just slide this stone up, and then with the left hand we have to catch at the level of Hartmann. So, this is sliding the stone and holding by the left hand below the stone and now giving the anteromedial traction, and after giving by the left hand anteromedial traction, we will separate the posterior peritoneum and above the Rouvier sulcus, and at least 1/3 of the gallbladder, body of the gallbladder posterior peritoneum should be separated, and at that time left hand should give anteromedial traction. If you are using harmonic, then the Teflon jaw of the harmonic should be kept towards the gallbladder so that it should not perforate, and only peritoneum should be separated, and that will give you the very good, always above the Rouvier sulcus we should do that dissection. After that anterolateral traction will be given, and then anterior peritoneum will be separated. And if you will give a good traction, immediately your posterior window will form. We can see here posterior window is formed and cystic plate is visible. And inferior surface of Calot's triangle of laparoscopy, one of the boundary is inferior surface of liver, which is clear cut visible. After that we will make an anterior window by the Maryland, and that is in between the duct and artery. So, you can see both the windows are formed, and then we will put the ICG mode on to check that critical view of safety is nicely visible. You can see common hepatic duct is visible, CBD is visible, cystic duct is visible, gallbladder is visible, and artery is not stained because artery does not take the ICG. If you want to see the artery, you have to inject right now. This is Auro green, that is the Indocyanine green which we are using for. So, this is posterior window and this is anterior window. Now, we will feed in the anterior window this vicryl, number 1 vicryl, and we will feed it 20 centimeter inside. so that when we will pull the tip of this suture out, there should not be any shearing effect. So, this is the extracorporeal knot for the continuous structure, and the artery is slowly feeding the in between the artery and duct, and now you will take it out and you will ligate it. So, what is the configuration? Configuration is Mishra's knot is 1 1 1 1 1. So, you will take a single hitch, that is one wind, and then you have first hitch and then one wind and then one lock. So, one hitch, one wind, one lock, and after locking it again one wind and again one lock, and then again you will do one wind and one lock. So, basically in this you have a 3 wind and 3 lock. So, this is Melger's knot has a configuration 2 3 2, Rodard's has a configuration 1 3 1, and the Mishra's has a configuration 1 1 1 1 1. So, this is very secure knot up to 18 millimeter structure. Now, excess of the tail is trimmed, and now with the Vandarkar knot pusher we will slide this knot and we will ligate the cystic duct. And at that time ligation you should not give any traction over the CBD, so that it should go at the junction, automatically it will go to the junction, and only one knot is more than sufficient, because knots are either exactly right or hopelessly wrong. You can see very nice dumbbell is formed, and this one knot is sufficient. Knot has many advantages. One of the biggest advantage, it cannot do lateral clipping and it cannot do cat eye stone. After that we will apply one clip towards the gallbladder. However, you can apply knot also, but purpose of this clip is just to prevent the leak of the bile. And one of the biggest advantage of knot is that late complication of clip will not happen, that is cat eye stone. So, now one clip applied over the artery as well, and first we are cutting with the artery with the harmonic scalpel, and after that you can cut the duct, and then easily it will be separated. So, in many situations in the acute cholecystitis, if you will perform, when you are cutting the duct you should relax it so that it will seal better, especially with the harmonic. So, I was telling that in acute cholecystitis, if you will perform the surgery earlier, the surgery is easy, because this edematous gallbladder, it will easily come out with the liver, because it has a inflamed and areolar tissue plane will open and it will be easy. Adhesion is the only problem if it is acute and chronic. Otherwise, for acute cholecystitis, laparoscopy is the method of choice to perform. However, if you will delay it and if you lump is formed, liver enzyme got raised, then it is little difficult. So, now we can see easily gallbladder is separated from liver. After that we will take a claw forceps, and that claw forceps will hold the clip, and then it will taken out easily by the epigastric port. So, claw forceps clip should be in between the jaw. Sometime if you have a large stone, you can put one artery by the side of the wound and you can stretch little bit the rectus sheath. So, here rectus is stretched and then gallbladder is taken out. So, thank you very much for watching this video.